um, as most people know, I've been award attending for 40 years. And over those 40 years, I've noticed that the understanding of how to interpret lab tests is not as strong as the understanding of how to take a history, which is not as strong as it should be. And there are some articles that have been written that people order lab tests and don't know how to interpret them. For those of you who are not at UAB, for years, probably 20 years now, I've done an acid base and electrolyte session once a month at the VA. It must be successful because they keep inviting me back. And I was trying to think of an idea, and this actually happened in the chat room at Virtual Morning Report. I mentioned that I might do a podcast on lab tests, and a couple of students said, you really ought to do something like the Virtual Morning Report because it's so much more fun to try to work through a case with the presenters, and then you learn more because it's more active participation. I should have known that. I didn't until someone suggested it. It sort of struck a light bulb for me because I keep telling people if you're gonna give a talk in medicine, you really ought to include cases to make your points rather than trying to have a really boring set of PowerPoint slides. So this is our attempt, and this is not just going to be acid base over time. We have plans to look at all different kinds of labs so that we can interpret them better. And we came up with the, we're trying to talk about remarkable labs and then sometimes labs that seem like they're not remarkable. And there was a wonderful example of this at Virtual Morning Report yesterday. So that's why we decided to call it unremarkable labs, because sometimes they really are remarkable. So Courtney is frozen. Can you talk, Courtney? Courtney, if you can hear me, you probably ought to try to check things out here. So while Courtney's trying to straighten things out, Jeff, could you just introduce yourself so that the people who don't know you will know who you are?
Hey, I'm Jeffrey. I am an intern, about to be a second year here at UAB. I'm really interested in learning about how to diagnose things, and I really like listening to the clinical problem solvers. Talked with Dr. Centaur a little bit earlier, I think this month, about possible opportunities of things like that, and he told me about this podcast, and so I was really interested and really excited to see what this kind of goes on.
Yeah, you're PGY2 in 12 hours.
It's not PGY2 yet. Don't make me nervous.
Are you on call tonight?
Don't make me nervous.
You're not on call, you're PGY2.
All right, fine. I'm PGY2.
Is Courtney's system working now? Courtney, poor Courtney. Courtney froze. I tell you, she'll catch up. Sean, are you or Steven gonna start us out here?
We'll be starting us off.
Okay.
Steven's going to be pulling up the whiteboard and running it.
Jeff, close the chat, and I'm closing the chat. They'll be watching it. Okay, go ahead and start, Sean.
Okay, so I have for your pleasure today BMP. The sodium's 139, potassium's 4.1, chloride is 95, bicarb is 34, BUN is 50, creatinine is 3.2, and his glucose is 115. So, Jeffrey, what do you think when you see this? I'll give you a little bit more information. This is a middle-aged gentleman in his 50s who came in with nausea and weakness.
Okay. So a couple things stand out to me right away. The creatinine is 3.2, which is, well, we don't know if he has a history of kidney disease or not, but assuming he doesn't, could indicate some type of kidney issue. And then the bicarb of 34 is above the normal range. And at this point, we still aren't able to really know if this is alkalosis or not, because we don't really have the respiratory component and the pH. So that's kind of what I'm thinking right now.
Okay, so let me expand. That's a great start, Jeffrey.
Sorry, I'm back. I don't know what happened to my connection.
Okay, so
But I
that's
agree.
fine, Courtney. You get to go next. So Jeffrey just
Okay.
went over this, and I'm going to sort of repeat. We have a creatinine of 3.2. That could be chronic kidney disease. That could be an acute kidney injury. That could be volume contraction. It could be obstruction. We don't know. And one of the really important things is to not jump on the term acute kidney injury, because that might stop you from actually evaluating it. So we don't know what to do with this 3.2 just yet. It'd be nice to have some old records. It'd be nice to look at a urinalysis. Be nice to assess his volume status. Does he have a reason for obstruction? And so that's sort of a placeholder. What I really loved is that Jeffrey did not jump on, is this alkalosis or not? So a bicarb of 34, and this is why he is now almost a PGY2. He's seen a lot of bicarbs of 34 that are in COPD patients, and we don't know if this is a COPD patient. So when you see the bicarb of 34, you want to figure out, could this patient be compensating for respiratory acidosis, or could it be a metabolic alkalosis? Now, he had nausea. Did he have vomiting also, Sean, or just nausea?
He had a few episodes, but nothing terribly severe.
Okay. So if he has an alkalosis, then we'll have to figure out how to evaluate that. And we still have to figure out the kidney disease. Now, the 50 BUN with a creatinine 3.2 is not exactly 2-to-1, but that's a pretty high BUN for that creatinine. So there's a lot more information that we're going to need. Courtney, what else? What would you like to? Sean might give us some answers. We might be able to order some labs. What do you want?
I think if we can't get baselines, which we talked about, I think that would be important to just understand, baseline renal function. And then either a VBG or an ABG, I think would be helpful.
So how do you decide,
I don't really have a.
How do you decide between VBG and ABG?
I think it really depends on, I guess for me, I just think of ABGs obviously as being more accurate, but they're sometimes a little bit more difficult to get. Whereas a VBG, that's something that would be a little bit more simpler. And then really, the main thing I'm looking for right now is to know what the pH is and what the PCO2 is. So I think at this point, I don't have a strong deciding factor as far as which one to get for this particular patient.
Yeah, I like that, and this is the way I'm thinking about it, and I've really changed over the last 2 years. What I really want to know is, am I just worried about the acid-base disorder, or am I worried about an oxygenation problem? And if it's just the acid-base disorder, the VBG does a pretty good job. We know how to adjust it. If we're worried about oxygenation, now we haven't seen the patient yet. We don't know if he has COPD. We don't know whether he's altered and not breathing well. So I would hold off on making that decision until we get a little more information. Although a VBG is so easy that if you want to get the VBG just to figure out if it's a metabolic alkalosis, then we're probably not going to be that concerned about the oxygenation. But we do get extra information from the arterial blood gas. So I think that was great, Courtney. So Jeff
and being on
asked
renal
Sean
consult.
questions. Do we have a VBG, Sean?
We don't have a VBG, but I can give you an ABG if you would like.
We'll take the ABG.
If you have to. So it's 7.46, 49 for his CO2, and then his O2 is 70. And I can give you a little bit more history. This is a gentleman.
And that's on room air.
This is on room air.
Let's stop right there and let's let Jeff. Actually, we're going to let Courtney, because Courtney asked for it. So we're going to let Courtney interpret that ABG.
Okay. So we're dealing with an alkalosis just by looking at the pH. I mean, it's obviously not extremely high for an alkalosis, but I kind of consider 7.4 for my mental baseline.
Mm-hmm.
And then as far as looking at the PCO2, right now that's elevated. So that's indicating some type of respiratory compensation in my mind. And then I'd probably have to do some type of, I'd have to go and calculate to see if that's appropriately elevated. But I think we're dealing with a primary metabolic alkalosis, and then to be determined if it's an additional respiratory component.
Right. So I'm the only compensation I can remember is Winner's equation for the metabolic acidosis. So I'd have to look it up. I'm guessing that that's appropriate compensation. The other thing that I think is useful here is because we got an ABG, we can tell that the lungs are in really good shape. How can we tell that, Jeffrey? Well, I'm glad I asked that question.
Well, because I guess first of all, the CO2, if it's actually compensating for the metabolic alkalosis, then we know that it's working.
Mm-hmm.
So we're not really worried about a primary respiratory process.
Okay, so I'm going to get Jeffrey. Let me give you a clue of something that anybody who's on my service, I go bananas teaching this.
All right.
Is every time you get an ABG, if it's on room air, just look at the AA gradient. You remember the AA gradient? I know you were taught that.
AA gradient. That's the difference between the alveolar oxygen pressure and the arterial oxygen pressure. Right.
Okay. So just not that it's going to help us figure out why he has a metabolic alkalosis. Let's go ahead and just go back over how you actually do that. So okay. What's the alveolar O2 on room air approximately?
Alveolar O2 on room air.
Yeah.
I'm not sure.
Good. Good. Courtney, do you know?
Is this when we use the pulse ox?
Nope.
Oxygen. Okay.
No.
I know I've done this multiple times and now I'm struggling.
Good. So I am so happy I asked this question because obviously this has not been taught properly. So remember, 760 is approximately the partial pressure. You subtract out water vapor pressure, that's about 47, that gets you down to 713. If 21% of it's oxygen and you multiply that, it comes out to about 150. Now this is going to be different in Denver. It's going to be a little bit lower in Denver. So that's the alveolar O2. The arterial O2 is what?
70.
Plus. So you have to include the CO2 to do this calculation. And you're supposed to divide by the respiratory quotient. Remember that? Okay. Somebody taught you that once. You said, why the hell are they teaching?
I remember seeing a formula once.
Yeah, you saw the formula once. Okay, you can actually just plug this into MD Calc and it'll do it for you. But you divide by 0.8 because that's usually the respiratory quotient. So if you do that, divide by 0.8 and add that'll end up being 49 divided by 1.28 is like multiplying by 5/4. So that'll be about 71 plus 70 is 140. We're subtracting that from 150. There's almost no AA gradient. Right. And they made up these numbers because people in the 50s don't have that low an AA gradient. He'd have an AA gradient of about 20. So I don't trust the chief residence numbers. Does that make sense to everybody? If somebody check the chat, if that explanation did not make sense, this can actually help you sometimes to be able to do this. If someone's on a vent and you want to know their AA gradient, you have to know what their FiO2 is. If they're on nasal cannula, you cannot really do it.
Dr. Centaur, is there an age correction that needs to be factored into?
The AA gradient increases with age. And so you would expect at age 50, and somebody can look it up for me. I don't know exactly, that it would probably be in the 20s to 30s. And once you get to my age, you know, I might have an AA gradient of 35 or 30, whereas you would probably have an AA gradient of 10 or 15. So
This guy has
there's a little bit of an age
18.
adjustment. What?
This guy has an expected AA gradient of 15 or 18, excuse me.
18, and so 10 is a little bit low. Yeah. Okay. So now what else do we want to know from Sean? So we've sort of taken care of his lungs are in really good shape.
I wanted to bring in one more question from something from the chat that I wanted to get your opinion on before we moved on. So as Courtney mentioned, sometimes practically, sometimes the ABG is a little hard to get. So maybe you get the VBG first. How do you feel about when there's correction factors for if you have a VBG and you want to estimate what the pH or any other component of it?
So I don't remember those correction factors. I have to look them up because I've been such an ABG purist until recently. But the corrections are pretty darn good for the bicarb and for the PCO2. They're worthless for the PO2. So if you really care about the PO2, you have to get an arterial blood gas. And the pulse ox can fool you because, for example, if someone comes in and has a pulse ox of 96, and you say, okay, they got no problem, but their PO2 is 75 and their PCO2 is 20, they have a huge AA gradient. And if all you're doing is looking at the pulse ox, you'll miss the fact that they actually have a serious lung problem, and maybe they had a pulmonary embolism because the pulse ox looks so good. So the pulse ox is good in many circumstances, but it doesn't tell you whether the oxygenation is as good if someone is hyperventilating. And by definition, hyperventilating is a low PCO2. So by definition, this man is hypoventilating. Does that make sense? The chat's quiet and happy. Okay, so Courtney, what are we doing next? Sean's going to give us more information.
I guess I'd be curious, just kind of trying to think through some reasons why somebody would have metabolic alkalosis.
Perfect.
So I generally think of like vomiting or like NG tube, suctioning out gastric contents.
Okay, so Courtney, hold on for a second. Let's get two big categories. There's two big categories of metabolic alkalosis. So what was the category that you were just starting to give us some thoughts about?
Like upper GI loss.
So volume contraction and upper GI loss. So contraction alkalosis.
Correct.
Okay. What's the other big category?
Metabolic alkalosis. I think of I guess issues with aldosterone. And that's not a good bucket though.
It is a good
bucket. But that's with like lower potassium and hypertension.
So the bucket is or renal function, and it could be aldo. It could be something that mimics aldo. There are of inborn errors of metabolism that can do that. There are medications that can do that. So Jeffrey, how are we going to distinguish between this volume contraction thing and the aldo or aldo-like group?
So one thing that we could do is we could take a look at his vital signs and a physical exam on the vital signs. I would be looking for like his blood pressure. If his blood pressure is low,
so if he has obvious volume contraction, that helps. But if you go back and read the JAMA article on assessment of is this patient volume contracted, we're not very good at it.
Right.
So there is a lab test that is recommended in this circumstance.
That would be urinary chloride.
Bingo. That's exactly right. So if this guy has been vomiting a lot, what's his urinary chloride going to be?
Should be low.
Correct. And if he has an Aldo problem,
Should be
it's going to
high.
be high. Right?
Yep.
So if we get that, then we can start to narrow it down and go down one of those two buckets. Does that make sense to everybody?
Mm-hmm.
Okay. Can you give us that, Sean?
I actually can't, but what I can give you is his calcium, which is 12, and an additional bit of historical data that he has been having a little bit of dyspepsia and taking some over-the-counter remedies to try to help with that.
Okay, Courtney, what is he trying to get us on here?
Like milk alkali.
Okay, do you know why it's called milk alkali?
Oh, I feel like I have heard you talk about this before.
Yeah, I tell this
And it
story
has
over
to,
and over again. I've probably told this story like 3,000 times.
yeah, it has to do with, I want to say just the treatment for dyspepsia and what ended up happening with it. And it's something to do with milk causing metabolic alkalosis.
Right,
But
and
that's where I
Sean
stopped.
remembered from when I taught him because he just put in the chat. So, did you know? Have you heard this before, Jeffrey?
Yeah, I kind of have. I think something to do with, I want to say calcium in some of the supplements that they use for antacids or something like that.
So back before the modern era, and the modern era started about when Hudebert finished his residency, which is like 8 years after me. The most common operation in the United States was a Billroth 2. And that was an ulcer operation. And before you got a Billroth 2, you had to be on the SIPPY diet. And Sean put that in the chat. SIPPY was the name of a surgeon. The theory then was that ulcers were all secondary to too much acid. And so we had to counteract the acid. And so the SIPPY diet was 5 small meals a day with a lot of dairy, a lot of milk, plus Tums or anything like Tums. And so it was milk and alkali. And that's why it was called the milk alkali syndrome. We don't see that for the same reason anymore, but we still do see it. And this story gets presented periodically at Morning Report. It's been presented at Virtual Morning Report with the clinical problem solvers. Some people will, rather than take Pepcid or omeprazole, will go ahead and take a lot of Tums. Now, why would that give you a creatinine of 3.2? So the alkalosis could be because he's ingesting so much alkali, but that doesn't get you in trouble until your renal function where you can't excrete it. Now he has, why does hypercalcemia cause this kind of renal dysfunction? And what question are we going to ask him now that will sort of clarify all this? So Jeffrey is staring at me as if
I know calcium can impair renal concentration of just like the concentrating ability of the kidneys. I'm not completely sure if
it has a fancy name.
Nephrocalcinosis.
Well, you can get nephrocalcinosis.
Okay.
That's certainly true, but that's before you get nephrocalcinosis. What do you get? Do you know, Courtney?
No.
So it's nephrogenic diabetes insipidus.
Oh, okay.
Oh.
Because calcium interferes with ADH attaching to aquaporin 2. And as soon as the calcium comes down, the nephrogenic diabetes insipidus goes away. So one of the classic presentations of hypercalcemia. So these are the questions we're going to ask him now. Did he have polyuria? Did he have a lot of nocturia? Did he have constipation? And obviously is confused because we know and those kinds of things. So polyuria, nocturia, and they often get constipation. So if you get enough polyuria, then your creatinine is going to go up, and then you can't get rid of the alkali. Does that make sense? So most nephrogenic diabetes insipidus is either this, hypercalcemia, for whatever reason they have hypercalcemia. What's the other big cause that we see for nephrogenic diabetes insipidus?
I always think of lithium.
You're 100% right.
Yeah.
You're 100% right. Now, there are other drugs that can do it, but the most common ones that we see in internal medicine is a patient on lithium or hypercalcemia. So in the differential, in the pearls, it is the hypercalcemia. It's not milk alkali, because if someone comes in with cancer and a creatinine of 14, they're going to have that same problem. So how are we going to figure this out? So the other thing it would be nice to know is what his albumin is, because this is a high calcium, but it's not a really high calcium. And anytime I see calcium, I'd like to know what the albumin is. So do you have that, Sean?
I don't have the exact number written down, but if I remember right, it was like around 4.5 or so.
Okay. So now what do we want to do for this guy, Courtney?
I'm trying, I think one thing I would have wanted before we went into some of this is just a urinalysis.
Okay.
I guess to see how dilute the urine is.
So
and then maybe a urine sodium.
So what do you think his urinalysis is going to show if he has nephrogenic DI?
I guess the specific gravity would be lower.
Yeah. Yeah. So he's going to have a dilute urine in the face of volume contraction. Now, if you're my resident at the VA and this guy comes in, I'm going to hope that you're really good at bedside ultrasound, because I'd like to see what his inferior vena cava is, because I suspect that he's really volume contracted, but we can't tell from his urine because of his calcium. So normally we could say he has a concentrated urine, but because of his high calcium, that and we could get urinosms and they're probably going to be relatively low. So the urinalysis, as much as I love the urinalysis, and the specific gravity, as much as I love the specific gravity, is not going to help us in the face of hypercalcemia. So we're going to have to use other things. We can deduce that he's probably volume contracted. We can do all the maneuvers and see. So it'd be sort of nice to go back and do a physical exam and see if it looks like it and ask him questions. Sean, if we go back and ask him these questions and examine him, what do we find out?
So you would find out that he has a very, very flat IVC, and he is slightly orthostatic. And the chat is talking about giving him some saline, and he did get IV fluids, and that essentially corrected basically everything. And
it all makes sense. It makes sense that fluids would totally fix this because of the mechanism. Then you got to get him to stop eating Tums. So this is something that I do on rounds all the time. So I'm going to ask Jeffrey and Courtney, what's the most important thing they learned from this case? So Jeffrey, I'll let you go first.
Definitely very interesting to learn that hypercalcemia can cause nephrogenic diabetes insipidus, even with the calcium that's not extremely elevated. I feel like that was really good to learn.
And Courtney?
Well, one thing that I have been actively working on this month, being on Renal Consults, is getting better about utilizing urine lights. So the tidbit with urine chloride, and just making sure that that is something to potentially assess for like volume contraction. Although a lot of times you know it just by the clinical picture, so it might just be, you know, for like learning purposes, but
yeah, it sometimes is a test question, and so it's worthwhile to know that that's the right test, because we didn't even get into if his urine chloride were high, how we'd work that up. But we can save that for another time, because I think Sean wants to give me one more case, right? Or should
So
we?
it's actually Steven's turn, and I will
Steven's
hand it
turn.
off to him.
Okay, if it's okay with everybody, we'll keep going. The chat's pretty active. Wow, 96. Woo.
All right, let's move on to the second one. So I'll give you a little bit of history. So this is a 30-year-old woman who's coming in with nausea, vomiting, and abdominal pain, who has this BMP. You guys tell me what you think.
Okay, Courtney, you get to go first this time because you're actually on here now.
yeah, so there are a lot of what I would think of as red numbers there. So low sodium, elevated potassium, the BUN and creatinine jump out at me, obviously as being elevated, and the sugar, obviously, and then as far, gosh, this chloride is very low. And then the bicarb, I almost don't like that it's normal. So I want to just at least calculate a gap too.
Thank you. You just made me
yeah.
so happy, Courtney.
So, I'm going to make me struggle through math here.
Yeah. So, if anybody
120 minus.
Asking medical students or residents to do math in their head is cruel and unusual punishment.
All right. So the gap. Are we making me do the gap right now in front of everybody? Okay. So.
Well, somebody wrote it down in the chat, so I'll let you cheat, and we'll use the chat. Actually, it's a lot easier.
Okay. Thank you.
When you're not the person who's having to discuss it. So the anion gap is 30.
This is an extreme. Yeah. This is a really high anion gap.
Absolutely.
So
what defines a high anion gap?
Honestly, I think anything above 20 is making me nervous. And then from there, I'm sure there's a better definition, but that's when I pay attention if there's a gap, but there's something really going wrong to me if it's above 20 anion gap.
So, couple of teaching points here. There was an article in the New England Journal, and they could almost always find the organic reason once it got to 25, and they could always find it once it got to 30. So you're obliged at least at 25, and I agree with you. I feel obliged at 20. Especially when you have something in the 18 to 22 range, it's nice to know what the albumin is so we know what we're comparing it to. So an anion gap of 20 with someone with an albumin of 2 is a really high gap. The technical formula, if I can get this right, is 11 minus 2.5 times the difference in the albumin from 4, including the sign. Nobody can remember that. You had to be a total nerd to remember that formula. So what we've always done at UAB since I've been at UAB is just multiply by 4. So now let's just stick to the acid base part, and then we'll get to all this other stuff. We have an anion gap of 31. So we know there's a metabolic acidosis, but you're totally confused because the bicarb is normal. So how can that be?
I mean, I don't know if Jeffrey wants to go, but I
Jeffrey
can.
save you here. Jeffrey, can you figure that one out?
Yeah, so I mean, the first thing that when I saw, all these derangements with the normal bicarb is that sometimes you can get fooled if you have a process causing acidosis and a process causing alkalosis at the same time. It can make the bicarb look normal.
Right. Okay, and this is actually a not unusual presentation to have an anion gap acidosis and a metabolic alkalosis. There are different ways of documenting that. There's a delta. The way that I do it, the way I teach it is the delta gap. Let's assume a normal albumin. If it's a normal albumin, there's an excess gap of 19, right? Because we should have an anion gap of 12. We have a gap of 31. That 19 would be bicarb if we got rid of it. So we can add the 19 to the 25, and we can see that this guy, or is it a woman, would have had a bicarb of about 44. So so now let's see if we can figure out the story. So we have a lot of information here to figure out the story, Jeffrey. What do you think?
Yeah, this seems to me like my first guess would be DKA.
Absolutely.
The glucose is really high.
Okay, so what happens as you're going into DKA? What's the first thing that happens?
First thing that happens.
That explains the metabolic alkalosis.
Volume contraction.
Right. So we get polyuria, an osmotic diuresis. Then we develop the keto acids, and that's why the bicarb is normal. Does that make sense, Courtney?
Mm-hmm.
Okay,
so now we got a metabolic alkalosis and
Dr.
metabolic
Bob,
acidosis.
there's a quick question in the chat about why you're looking at the albumin when you're calculating the gap, which I think is pretty fundamental to this.
Great question. So the gap is normally made of mostly albumin. That's the major missing anion. And so when the albumin goes down, the gap goes down. When the albumin goes up, the gap goes up. And so it's probably a proxy for other things also, but that's the main reason.
I wrote it out and see if it makes sense or not.
What'd you say?
Yeah, Dr. Hudebert mentioned in the chat that albumin is negatively charged.
Correct.
So there would be less cations, making the anion gap falsely low, as less cations are needed for electroneutrality.
That's exactly right.
I wanted to mention one more thing. Do you have a comment on, should we have corrected that sodium before calculating our gap?
No. Already on the chat.
That is such a common question. I'm so glad you asked that question. The correction for the sodium, if we could actually do the correction, because the correction is not very good, is also the correction for the chloride. And so everything is lowered by the glucose. It's not just the sodium. And that it's very clear that you do not correct for that when you figure out the anion gap.
Already warned them also about your concerns about how to correct sodium for glucose in the chat.
So we actually did a study a number of years ago where we looked at people who had elevated glucose and low sodium and measured serum osms. And they were all either normal osms or elevated osms. And probably the reason is this. The two studies that were used to estimate the correction factor used normal people who didn't have diabetes. They raised their blood sugar. One raised the blood sugar, but didn't have enough time to change the volume. Once you change the volume, it just messes everything up. The other one was a theoretical mathematical formula, but it also didn't take into account the decreased volume. So if you're worried, and I would not be worried by sodium of 120, with a blood sugar of almost 700. If you're worried, get a serum osm. But it's almost never hyponatremia. So what do we think of this potassium of 5.7?
So in my mind, with this particular type of patient, I'm always going to be worried about their total body calcium or potassium, just because of the shift that happens during acidosis. And so I know that that's just something that we want to make sure we're monitoring within DKA. So my guess is this is not necessarily like yes, it's elevated and I should be worried about it, but overall, I think this person's probably hypokalemic.
That is so right at so many levels. I think it's worthwhile to go ahead and look at the EKG, make sure it's not a scary EKG. But I'm going to monitor that potassium really closely because I've seen these go down in the 2s. What about the Jeffrey? What about the BUN and the creatinine?
It looks like that this patient's having a severe AKI. They're both really elevated.
Well, but is it really an AKI or is it just volume contraction?
That's a good question. Not completely sure. I mean, we can see how much it improves with volume. Resuscitation.
So, so we want to ask the patient if she's peeing a lot, and then we want to see when we give fluid, is there a big urine output?
So I think that's a great question to kind of move the case along. So I will tell you guys, she has not been peeing, but that's not abnormal for her. She has ESRD and has for the past 2 years.
So now what are we going to do?
Well, giving her fluids in this situation, I think would be definitely a recipe for somebody becoming overloaded in a dangerous way. Because I think of DKA also as just being, they're generally in my mind volume depleted. So, but if somebody's ESRD, then that changes it a little bit.
Okay, so how are we going to treat her?
I mean, dialysis is what I want to go to, but I'm trying to also think in the meantime, what do you do while you're getting her set up for dialysis? But I guess she at least has easier access being ESRD.
Do you want to give you want to give her insulin?
Oh, yes, but yes, I do. I think I haven't really worked with a DKA patient who is ESRD, and just being sure that I guess you'd have to also give her sugar too at the same time, so you're not dropping her too much.
Well, I think
she has a lot of room to go, but. Yeah.
So I think there are a couple things. First of all, she belongs in the unit. Second of all, call Talwani. Third of all, start giving insulin and checking very, very frequently to try to get the glucose down, and then see what the sodium does with that and see what the potassium does with that. My guess is the potassium will shift into cells. Now, the thing that makes this complicated is the reason that we thought that she was going to have a metabolic alkalosis, because she has both a metabolic alkalosis and a metabolic acidosis, is that she was going to be volume contracted. Could she be volume contracted without, is she anuric with her end-stage renal disease, Stephen?
She's almost anuric. She pees maybe once a day at baseline.
Yeah, so we're going to have to think about that and see what happens. My guess is dialysis will fix a lot of things. It won't fix the glucose. And does she have a history of diabetes, or is this brand new diabetes?
She does have a history of diabetes.
So I guess we have to assume something has happened. She's gotten sick. She's got this abdominal pain. The abdominal pain and the nausea could all be from the glucose. And so we have to see how much that corrects. So tell us what happened, Stephen.
Yeah, so this is actually not the first time she's presented with nausea, vomiting, and abdominal pain with DKA. She has a history of gastroparesis and comes in about every 3 months with a similar presentation, is intolerant of food, throws up 10, 15 times in the day. So we gave her some fluid and her alkalosis resolved, and we gave her some insulin and her gap resolved as well. So it was probably a mixture of DKA and gastroparesis, and by the next morning her BMP looked like any regular healthy ESRD patient.
That's really great. So let's bring up one other thing just to finish this off. What's different about this patient is that she doesn't have good urine output. If she did have a good urine output, a normal DKA patient, what other electrolyte abnormality would we be concerned about as we're treating their DKA? That's not on the board here. That is very dangerous.
Phosphorus.
Exactly. So hypophosphatemia. So if the patient has been sick for a while with developing DKA, they're phosphaturic, and then as soon as we give them insulin, it combines with glucose, and you start using up more phosphate, and you can get very dangerous hypophosphatemia. And maybe in a future one of these sessions, we can talk more seriously about hypophosphatemia. But we're getting towards the end here, and again, I'd like to have Jeffrey and Courtney give their thoughts about thinking through this case, and then let our wonderful chief residents make some comments.
Definitely one thing that I learned that was really helpful is that you don't correct the sodium when you're calculating an anion gap in these patients, because sodium and chloride are both affected by that hyperosmolar state.
Great. Courtney?
I think that just thinking through DKA patients who have ESRD, and that IV fluids and insulin are still appropriate treatments.
Yeah, and it would have been a lot easier if you'd known that she had gastroparesis and she'd been vomiting a lot of times. But that's okay, because what we're trying to do is make sure we can milk everything we can from these labs. And we'd then go, when we were setting this up, Seema, Sean, and Stephen and I talked about this. A lot of times you get a call from the emergency department or from the clinic saying that we're admitting a patient to you and they have abdominal pain, nausea, and vomiting. And before you go down to see the patient, you go look at the labs. And so if you understand how to analyze the labs, then you can do a much better job of taking a history and understanding the importance of the history with the labs sort of as a background. And so that's one of the reasons that we're doing these sessions, is so that we can better understand what are the possibilities here, and then get more information from the patient to make this picture all make sense. So Seema, were you the pearls person? Were you in charge of pearls, or was Stephen?
I'm in charge of pearls right now.
Oh, Sean's in charge of pearls. So what do you think are the big takeaways from these two cases?
So I think I'll start with this one first, since I can see it right now. But I always forget that you don't correct that sodium for the anion gap, just echoing what Jeffrey said, because when you do see that glucose of 668, the first thing you do is, that standard rounding thing, and bump that sodium up. The other thing is, I was typing out the mnemonic kill you, just to remind us all of what metabolic acidosis causes are. And then I think on the first case, just remembering that hypercalcemia can cause a nephrogenic DI, like lithium can. And something that's kind of interesting that you guys had mentioned a little bit is his AA gradient's a little bit interesting in this case.
Well, I think Courtney and Jeffrey, first of all, they're very brave to do this. The very first one, and they did a wonderful, wonderful job. The chief residents, as usual, our chief residents are superstars. For those people who are not part of UAB, who were so nice to come and listen to us, please send me emails and encouragement on whether we should continue to do these. We have tentative plans to do some hematology ones and to do some rheumatology ones and do some liver test ones. And if this is a worthwhile exercise, we're planning to do this again next Tuesday. I'm going to be on vacation, but I'm still going to do this, and it's because this is so much fun. So I just like to thank everybody who came and listened and is going to give us feedback. And it looked like the chat was really busy today, and I really appreciate that. And I'm going to give the last word to my partner in crime and my buddy, Gustavo Hudebert. Gustavo, do you have any final comments?
I'm here to keep you honest.
You're here to keep me honest. You've been doing that for 25 years.
I'm getting good at it though.
Yeah, you are.